I understand what you're saying about the neck and vestibular being connected, and that the neck can block blood flow. But what I'm confused by is what I keep getting the advice in general to only treat one system at a time. One of my theories is that the neck is blocking for blood flow, and that's why vestibular treatment isn't working. I found neck treatment that relieves my lightheadedness, but I've been holding back. Oh, I'm combining it with my I'm combining it with my vestibular exercises because of the advice that doing one system at a time. Sometimes that's a really good point. Sometimes that will be the advice when there's uncertainty about how to approach it. So by doing one thing at a time, you can measure one thing at a time, and then you're less likely to. This is like a more scientific way to approach it because you can see what happens. And that's fine. That's one of the choice a lot of people are going to make. Without knowing the case and knowing exactly how to approach this, or giving online advice, I think it's really interesting that the neck treatment is helping. So if it is helping, I would be interested in seeing to what degree it's related to the vestibular component, if there is one, and how those interface with each other. And then look at how do you start to let them do that on a normalized basis. So you're always trying to get everything to you're pretending like you're trying to get back to like running around like a kid. And so, or that's the way I think about it. And so if you're trying to do that, you have to think about, well, I want to live a life where I can move my head and my eyes at the same time as run around and laugh and chase someone. So you have to be able to integrate all these things together. So at some point, once there's enough strength in that system, then we want to be able to drive that, if that makes sense. So what happens if you exceed that capacity and treat someone's brain that isn't getting enough blood? I would say one of the greatest focal points that I got in the early days of learning neurology with Dr. Carrick was this concept of metabolic capacity, which means you can only push something just beyond what it's currently capable of in order to make it grow. You can't push it super hard or you'll actually injure the tissue. And you can't push it not enough because it doesn't create a change. It doesn't give a challenge or a response, a challenge that creates a big enough response in the system. So what you're aiming for is you want to challenge the system, but just a little bit, so that it can recuperate and recover and get a little stronger, and then do it again, and then do it again, and do it again, and do it again. So most of what our training is actually recognizing the fatigue points in metabolic capacity. And you can see that's part of what we're looking at in exams. So like, when you do certain things with dual tasking, does a pupil get big, or does your eyelids start to close, or do you get to where you don't speak as fast, or does your face, do you kind of start to hold your mouth open? Does your heart rate go up? Do you start to sweat? Do you start to have a little shaking in your eyes? So all of these things are things that we're constantly evaluating while we're working with people, so you don't walk away. We're like glued to people like this the whole time, and we're looking for these little subtle changes, then we stop. So I'm very much aware of trying to make sure that we're not over capacity. I look at trying to solve for the cerebral perfusion as a starting place because it means that you can push them more. So if we can get them to where we have a higher capacity level to start with, because they're actually getting irrigated, you're getting blood flow, then it gives us more space to actually push people rather than just taking these little micro increments and hoping that we don't push it too far. So it's not a thing that I get scared of. It's a thing that I think about in order to help people as fast as possible and make sure that we're seeing all of those variables. So I look at blood flow as a major part of that. It's a good question. Do you see dysautonomia in Mal de Débarquement Syndrome patients? And we do. Mal de Débarquement in the classical sense, for those of you wondering, it's disembarkment syndrome. So it used to be kind of solely correlated to travel, boat travel, air travel, car travel, where you have a persistent sense of motion after you get off. And some people will notice this for a short time and it regulates. But in this particular case, it's chronic. It lasts for a long time and it's not going away. It usually feels a little bit better when you're moving. So like driving the car actually helps you feel better. That's kind of one of the classic signs. And we'll notice different physiologies of this in different people. Some people will have highly vestibular pathology where we see this decoupling of this vestibular component between the otoliths and the visual system, right? So that's kind of one common one. But another one we'll see is where we just see this rapidity of square wave jerks where the ability to inhibit them from kind of the frontal cortex down into the superior colliculus and then down into the pons, that little group fails. So it can be for different reasons. But in some of those cases, we'll see, especially those ones that affect that brainstem component, because we have that sense of motion, you're going to get a ramp up of activity in the autonomic system, which may overfire or overmobilize energy in that system. So we do look out for that for sure. And that is honestly one thing where some people will come in with MDDS, and then we talk about dysautonomia as a secondary part. And we're like, did you know you also have this? And then sometimes people will come in with autonomic problems and we'll point out like, well, this is actually a variant of MDDS. And we talk about that and we look at that Venn diagram crossover. So that's a really good question.